So I'll be going little fast because more than 2.5 hours chairman has no permission to continue the discussion. So in polytrauma, sustained injury is there, blood pressure is low, at the same time the pulse rate is high. Can you tell me what is the complication he is suffering? Pericardial tamponade. No talking in pericardial tamponade. Doing a pericardial tap with a pigtail catheter. You need to be aggressive cardiologist at that point of time, doctor. Then what in a case of tension pneumothorax, do you think diaphragm is elevated or depressed? It will be depressed. So what you can see here is this is the collapsed lung, doctor. This is the pneumothorax and it has expanded and made this diaphragm to become displaced in a downward direction. It has also pushed the mediastinum onto the opposite side. So classical pneumothorax you can't basically forget. So what you can do? You can place one chest tube drainage so that you can be able to deflate and enable the lung to expand once more. It's very important part of the management. Let's go to the next question. 25-year-old male in the road traffic accident had a fracture of pelvis. Then is it the posterior urethra or anterior urethra which is much more prone, and why is it more prone? It is the posterior urethra which is much more prone in such kind of traumatic cases. The reason is the puboprostatic ligaments are fixedly attached. So that is the reason any displacement of the bony pelvis will lead to tearing and shearing of the membranous urethra. So posterior urethra is much more vulnerable than the anterior urethra is what need to be remembered. But if there is any blunt force below to the perineum, then that crushing effect can cause anterior urethral, but generally it is the posterior urethra. Retrograde ureterogram is considered to be the gold standard of investigation, doctor, and by doing that you can know whether there is any extravasation because of this urethral injury, and this shows the appearance how the partial tear of the urethra with the disruption of the urethral continuity can be seen by doing the retrograde ureterogram. That's what had been asked. Can you place a Foley catheter? Any case of trauma, you need to be doubly sure that there is no urethral injury is very important part of the management. A girl presents with recurrent UTI, ultrasound shows hydronephrosis and there is a negative shadow of the bladder, no ectopic ureteric orifice, then what is your diagnosis? What do you mean by ureterocele? What is that adder, snake adder appearance on urogram? Now let us be clear about. Ureterocele is basically a saccular outpouching that is there at the distal part of the ureter when it is entering into the urinary bladder. And because of that there is a continuous recurrent cystitis with a bladder outlet obstruction, and most of the times patients are asymptomatic, but it is found radiologically. And there is one entity called ectopic ureterocele. What is the meaning of it? Here the orifice is located in an ectopic position. Instead of a regular location where ureter is opening into the bladder, it will be opening into the bladder neck or into the urethra. And typically in the pediatric population where you find ureterocele, you find an ectopic type of ureterocele is what need to be remembered. So the ultrasound of the bladder, ultrasound of the kidney is the first part of the evaluation in a suspected case of the ureterocele. If you do that, then ureterocele can be identified as a fluid-filled cystic intravesical mass, and it is called a cyst within a cyst appearance is what I want to underscore to all of you. So this gives you the typical picture when intravenous pyelogram had been performed. You can see that the left ureter is showing a hydronephrotic change, and the ureterocele is appearing like a what you call a round filling defect, and this is a typical appearance called shadow within the shadow appearance is what cyst within the cyst appearance. And ultrasound also can show you that ureterocele is causing a low grade obstruction is what can be seen. So ultrasound is a very important part. So adder head appearance, like a snake adder head appearance is what you see in the case of the excretory urography. Let's go to the next question. When you want to treat the BPH, only when the residual urine is greater than 20 on evaluation, then a severe obstruction is entertained, and that is the time where you have to do it. Do you want to do a radical surgery like a open prostatectomy? Are there any indications for that? If the prostate is very large, 75 grams, and concomitant bladder stones or bladder diverticula are there, and the patient cannot be positioned because of his cardiovascular reasons for a transurethral surgery, then that also is an indication for an open prostatectomy. And let's go to the next question. Testicular tumors, what is true? 90 to 95% of the primary testicular tumors commonly seen in the case of the cryptorchid, but not only in cryptorchid, there is another important thing. And high orchidectomy is considered treatment. AFP is not raised in all the cases. It depends upon, is it seminoma or a non-seminomatous tumor. So one question on testicular tumor or ovarian tumor invariably comes, doctor. 100 topic list you have to write it. Murphy's sign is seen in the case of cholecystitis. And what is that appendicitis, what you see? Murphy's triad is seen. Very good. Murphy's is if respiration is taken, there is a severe pain. The catch. Murphy's catch. Very good. Catgut, where do you preserve it, doctor? Isopropyl alcohol. 44-year-old has got a carcinoma of the prostate and there is a sclerosis of the vertebra. Then how did it go from prostate to vertebra? You need to remember that typically you have two types of plexuses called the internal vertebral plexus and you are having an external vertebral plexus. So this internal vertebral plexus, which is called the Bateson's plexus, is the one which will be transmitting from the prostate to the the vertebra, and once more through this plexus it also can go to the brain. So all these important plexuses you need to know. Let's go to the next question. Pancreatic pseudocyst, is it more common in the head or is it more common in the tail, is a very important question. Anyway, let us see that practically only. Why to have imagination in the mind? Because trauma, where is it very common? Trauma of the pancreas between head and neck junction. Head tumors are common. Tail cyst is common. So you can see this is the liver and you can see that the head of the pancreas is located here. The neck is over here, tail is over here. At the end of the tail you can see the pseudopancreatic cyst. And because the pseudopancreatic cyst arises from the tail, you can also remember it is through the stomach that you can approach the tail cyst and can be able to drain it out is what need to be remembered. Adenemic ileus is seen in the case of the peritonitis. Sclerotherapy, where do you want to do, doctor? Internal hemorrhoids. First degree internal hemorrhoids which bleed, sclerotherapy. And early second degree also you can use them to prevent the relapses. Where do you do the bilateral lymphangiography, doctor? Typically it is done in the case of the testicular tumor, Hodgkin's, but not brain. Brain, does it have lymphatic drainage? It doesn't have. So what is used in laparoscopy? Carbon dioxide is the gas. Renal cell carcinoma is otherwise called the Gravit's tumor, doctor. And renal cell carcinoma, does it metastasize to lymphatics or to the vessels? Hematogenous metastases are common. It can also invade through the vessel. So they are the two important features. Sometimes hematogenously it can go up to the choroidal metastasis can occur. It can cause a lytic lesions. The second right pedicle has got destroyed in this case compared to that of the upper ones, and the L1 and L3, L2 pedicle is being destroyed. And there can be a metastasis to the lung which can be pulsating, which can be hemorrhagic. So three conditions: renal cell carcinoma, hepatocellular carcinoma, choriocarcinoma. There can be pulsating hemorrhagic metastasis to the lung is something that should not be forgotten. What is the most common site for the obstruction of the gallstone ileus, doctor? Ileum is the narrowest zone where it can undergo obstruction. The best graft, a vascularized homograft is a better one. And in pregnancy, can you give radioiodine, doctor? It is contraindicated. Surgery can be done. In which trimester? Good. And Nelson syndrome means what? After you have done the adrenalectomy, suddenly pituitaries become enlarged. So that is called as the Nelson syndrome. Hyperpigmentation, pituitary enlargement in the post-adrenalectomy phase is what need to be remembered. And you have done the adrenalectomy for hypercortisolism. When do you want to start the cortisol? Immediately as the anesthesia is induced, you have to do that. Anytime you attended pheochromocytoma surgery, doctor? Very challenging surgery. It's a nightmare for the anesthetist. BP suddenly will be shooting like a rocket, suddenly it will be falling down, dopamine is started, dopamine is slowed. So finally, it is, if you are a good cardiovascular anesthetist or not, do you have a guts? You know, having knowledge is not sufficient, doctor, in clinical practice. You need to have guts also. So, is proven if you have anesthetized one surgery of pheo. Now, let's go to the next question. Indian file pattern, where do you come across? So, breast cancer in that infiltrating type. So this is a classical appearance, doctor. It is an invasive lobular carcinoma. It shows the cells which are basically like a Indian file pattern. They are aligning themselves. Is a classical feature which is seen in the case of the infiltrating type of the carcinoma. And it also shows what is this pattern that you see in infiltrating type of lobular breast cancer called as Dr. Targetoid pattern, that is like a target lesion, targetoid pattern. That can be a question in the tomorrow's exam. So you need to answer once more in the infiltrating type. You can find an Indian file pattern even in the case of any metastatic tumor, doctor, which goes to the liver. There also you can find another type of Indian file pattern. Let's go to the next question. What do you want to do for a mucosal of a gallbladder? Resect it. So, massive blood transfusion lead to hyper or hypokalemia. So here one fix is there for you. Typically it will be hypokalemia because potassium will be moving into the RBCs, whereas where do you come across pseudo hyperkalemia? Pseudo hyperkalemia will be found in a hemolyzed blood sample, but don't apply that logic here. So massive blood transfusions lead to hypokalemia, not hyper, is what need to be remembered. What is a premalignant lesion of the, what is not a premalignant lesion of the carcinoma of penis, doctor? Condyloma acuminata. Most common tumor of parotid is undoubtedly pleomorphic adenoma. Anteromediastinal masses, 3 T's you must tell me. T for thymoma, T for teratoma, T for retrosternal thyroid, T for terrible lymphoma. They are the 4 causes for the anteromediastinal masses. Neurofibroma presents like a posterior mediastinal mass is what need to be remembered. Renal vein, once more one of the favorite question of the exam. I think last exam also we discussed AP entrance, right? So left renal vein drains, doesn't drain into the, will it drain into IVC? Right renal vein drains into the IVC is what need to be remembered. And chronic renal failure, you don't find hypokalemia, you come across hyperkalemia. Sometimes if required you need to do dialysis to manage the hyperkalemia.